And I will get going just to give Dr. Novick her adequate time for talking about this important topic. So welcome, and thank you for joining us tonight for Module 3 of our Cutting Edge Nutrition series, which is an 8-part online module series with sessions held over the next 3 months. My name is Rebecca Shankman, and I am the director of the Villanova University Fitzpatrick College of Nursing's McDonald Center for Nutrition, Education, and Research, and the moderator for tonight's session. We are very grateful to Dr. Marsha Novick for presenting tonight. And before she begins, just a few housekeeping items to review, which I'm sure many of you have seen many times. Villanova University, Louise Fitzpatrick College of Nursing, is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. This activity awards 1 contact hour to nursing professionals. This activity has been approved by CDR for 1 CPEU as a level 2 activity, and we have listed suggested performance indicators for our fellow dietitians. To receive CE credit, you must attend the entire program, and please look out for an email containing a link to an evaluation, which will also include your certificate. But we do plan to send this out early next week. Instead of this week, which I know usually we send it out a day or 2 after, but please look out for that email next week. We ask that you do complete the evaluation soon after receiving it, and everyone is encouraged to complete the evaluation because we truly value your feedback and do look at every one of the evaluations to help plan future programming. Please note that for our nurses, you must complete the evaluation in order to receive your contact hour certificate. Just a reminder that if you are joining us, and that means you have received the Zoom link and the slides for tonight's presentation, the chat box will not be open, but we do invite you to send in questions using the Q&A box throughout the presentation, and we will address as many questions as we can at the end. And as a reminder, this presentation is being recorded. There are no relevant financial relationships with ineligible companies for those involved with the ability to control the content of this activity. The planners will review participant feedback to evaluate for real or perceived commercial bias in any activity. And now it's my pleasure to introduce Dr. Marsha Novick, who is the Medical Director of Weight Management and Wellness Online, a private weight loss practice serving adults and children in the District of Columbia, Maryland, Virginia, Pennsylvania, New York, and New Jersey. She is board certified in family medicine and obesity medicine and is a national expert in the field of obesity medicine. Prior to private practice in 2023, she was the director of the Penn State Hershey Medical Center's Healthy Weight Program for children and teens. She has over 20 years of experience and has treated thousands of children and adults with weight problems. Dr. Novick serves as a board member of the American Board of Obesity Medicine and writes questions for their board certification exam. She is a national lecturer on the topic of obesity and currently serves as a member of the Obesity Society's Ethics Committee, the American Academy of Pediatrics Section on Obesity, and the Pennsylvania Obesity Advocacy Group. She is also a medical consultant for Obesity Matters, an international nonprofit organization which educates and advocates for the public. Dr. Novick has collaborated with national research experts in the field and has published over 20 scientific papers on obesity. And with that, I welcome Dr. Novick tonight, and we'll see you back on here after your presentation. So thank you, Marsha.
Thank you. All right, I'm going to share my screen here. Welcome, everybody. Again, my name is Dr. Marsha Novick, and I would like to thank Rebecca, as well as the Villanova Center for Nutrition Education and Research. And I am honored to be here today to speak about the medical management of pediatric obesity, including some compassionate, stigma-free strategies that we can use. As mentioned before, I am the medical director of a private practice called Weight Management and Wellness Online. And some of the content today has been taken from Novo Nordisk. However, I am not financially compensated through Novo. For learning objectives, we would love to have you classify and diagnose obesity in the pediatric population, to use patient-centered, compassionate communication that is free of stigma and bias when communicating with children and adolescents with obesity and their families. And lastly, to discuss the role of lifestyle intervention and pharmacological therapies for the management of pediatric obesity. So if you get nothing out of the presentation today, is to know the following: that obesity is a chronic, complex, and relapsing disease. And what that means is that obesity needs to be treated like any other medical problem, such as diabetes. And that means that patients need to return to your office every 1 to 3 months for check-in. And early intervention is very important. The American Academy of Pediatrics recommends that screening start at the age of 2 years old. You can also see that obesity is highly complex. Not only is the gastrointestinal system, such as the stomach, the small and large intestine, and the pancreas involved, and send signal up to the brain. In addition, there are different parts of the brain that are affected as well, including the hypothalamus, which we'll talk about in a minute, and also adipose tissue, which again signal up to the hypothalamus as well. And this is a very complex part of our organs system, our body. But as we know, even at a Thanksgiving dinner where our brain is telling us and our stomach is telling us that we're full, well, there's always some room for pumpkin pie. And so our appetite can basically override all of these pathways. Unlike adults, where we look at the BMI, for children and adolescents, we define overweight and obesity by the BMI percentile. And so a BMI at the 85th to the 95th percentile for age and sex is considered in the overweight category. A BMI between the 95th to the 120th percentile is considered class 1 obesity. And a BMI between the 120th percentile to the 140th percentile is considered class 2 obesity. And any BMI over the 140th percentile is considered class 3 obesity. And the higher the class, the more likely there will be medical complications related to the weight. And with that definition, 1 in 5 children in this country have obesity. In terms of risk factors for pediatric obesity, there are many and are very complex. So we often think of diet and physical activity being culprits, but it's much more nuanced than that. For instance, the genetics and epigenetics play a role. Patients who have a heritage of being African American, Hispanic American, Native American, and Southeast Asian all have increased risk of obesity. In addition, the prenatal and early developmental factors can play a role. So if you have a mom who gains significant amounts of weight during pregnancy, has gestational diabetes during pregnancy, or smokes during pregnancy, all have increased risk of having children with obesity. In addition, there are socioeconomic factors, and I will talk about that in a minute, and environmental factors. So pollution to our food, our air, our water, as well as having places that are not safe to play, all impact the role of pediatric obesity. And finally, there are hormonal and endocrine factors as well. So this includes medications that our patients may be taking, as well as puberty. In addition, we need to be aware that there are big problems with social determinants of health that are basically not controllable. So low education, food insecurity, housing insecurity, minority status, living in a rural community, poor built environment, and low income all can impact pediatric obesity. And unfortunately, if you are poor in this country, you are heavily marketed in terms of the foods that we should not be eating. And we have spent a substantial amount of money to try to prevent childhood obesity. However, unfortunately, none of these interventions have worked. In terms of discussing obesity with our patients, we need to recognize that obesity is a complex and sensitive diagnosis, and it can be very difficult to have this conversation with our patients. However, we need to understand also that 2/3 of adult patients living with obesity would prefer to have their healthcare providers bring up their weight. And patients are more likely to attempt weight loss when their healthcare providers employ an empathetic approach and use techniques such as motivational interviewing. Another thing that we need to do is to look at our team, our staff, and to make sure that they're ready to care appropriately for our patients with obesity. We need to acknowledge that weight stigma and bias is very high in the medical profession. And so what we want to do is to use people first language, and I'll talk about that in a moment. In addition, it can be very helpful to have what we call an obesity champion. This is somebody who has an intricate understanding of the team that is in our community. These would include people like our registered dietitians, food banks, where to send our patients for physical activity or going to a physical therapist, psychiatrists, social workers, and psychotherapists all can play a role in helping our patients. In terms of weight bias in the medical field, it's important for us to understand that weight bias can be anywhere, and it's just important to recognize that we all have stigma and bias, and to try to make sure that we're aware of any bias that we may have. These biases can be included in our patient care as well. So chairs that are too small, it can be gowns that are too tight, or in my practice, unfortunately, we had advertisements for candy up on our walls. And we just need to be aware that this is information that our patients are dealing with on a day in and day out basis. It's also important to communicate well with our family members and to try to avoid stigmatizing or blaming words. So words that are preferred include an unhealthy weight or high BMI, instead of words like obese or morbidly obese or fat. Those are more descriptions. In addition, we want to use patient first language. So using phrases such as patient with obesity, again, using the diagnosis or patients affected by obesity instead of an adjective like obese. In addition, we want to have thoughtful documentation. Back in the day when I was working, we would have paper charts, and our patients really did not have access to those charts. But now our patients can look online and see what we're writing about. So instead of using terminology like obese belly, we wanted to use adiposity. Instead of using phrases like weight check, to use nutrition check or goal check instead. Now, starting the conversation can be really challenging. And so the recommendation is to try to use an open-ended question, such as, do you have any concerns about your child's weight and growth? You want to make the conversation clinical. You can also use the BMI chart to show why you're concerned about the child's health. And you should discuss the patient's in terms of health rather than their weight. In addition, it's really important to know whether the patient is ready to make change. And you would start that conversation by asking permission to see whether the patient is really ready for those recommendations. And a good tool that is used is called a readiness ruler. So you can ask on a scale from 0 to 10, how ready are you to make change, and how confident are you to make change? If they're at a 7 to 10, then they probably are pretty ready and you can set forth some goals. But if they're around a 4 or even lower, they're probably not ready to make those changes. And so instead of beating your head against the wall and having your patient feel really frustrated, it's probably better to talk about some education and to say, but I'm not placing any goals today. And if you would like to come back and talk about this at some other time, the door is always open. We also want to give hope and be compassionate with our care. So to say, if this doesn't work, that's okay. The weight is a medical condition and it's hard to treat. But the important thing is that you keep coming back to see me because if the plan doesn't work, there are other treatments that we can use and we can discuss those treatments and to potentially implement them. We also need to recognize that obesity is not the patient's fault. Patients with obesity often have tried multiple times to lose weight and may feel frustrated, have feelings of failure or low self-esteem, and experience mental health problems and internal bias related to these feelings of frustration. So it's our job to help our patients understand that body weight is influenced by many factors, including the genetics, environment, and hormones. So when a child tries to make changes in eating to lose weight, and the body resists that weight loss, this can lead to increased hunger and cravings and make it very challenging to lose weight. For treatment goals, we also need to know that obesity is associated with over 200 medical and psychological conditions. These include things such as sleep apnea, asthma and blood clots, fatty liver disease and cirrhosis, gallstones. There are 13 forms of cancer associated with obesity, stroke, heart disease, abnormal lipid profiles and high blood pressure, diabetes, pancreatitis, and women may have PCOS and infertility, and finally arthritis and gout. And so we need to remember that in adults, clinically significant weight loss is the equivalent of about a 5 to 10% decrease in body weight. Right now, there are no good guidelines in terms of how much pediatrics, children and adolescents need to lose. However, the adult information gives us some good guidelines. Again, that 5 to 10% decrease in body weight will significantly reduce the risk of many of these medical conditions. There are 3 parts of treatment. So the first is our diet, physical activity, and behavior intervention. The second is pharmacotherapy, particularly for adolescents, and then metabolic and bariatric surgery, also for adolescents. And today I will be talking about the lifestyle intervention and pharmacotherapy. The American Academy of Pediatrics recommends an intensive behavior lifestyle treatment for all patients, and there should be a patient and family partnership using a multidisciplinary team. And that team includes the primary care provider or another provider that is skilled in obesity care, also a registered dietitian, a psychotherapist, as well as an exercise specialist. And that this lifestyle treatment should occur promptly upon diagnosis of overweight or obesity. We want to provide health education and skill building on multiple topics, as well as behavior modification and counseling. The lifestyle treatment can occur either in a health setting or a community-based setting, such as a school or a rec center. And the American Academy of Pediatrics recommends at least 26 hours, contact hours, and ideally 52 contact hours in a 3 to 12 month period of time. Sessions can be in groups or individual or both. And the recommendation is to have face-to-face contact with the patient and the family. However, there is growing evidence that utilizing virtual means is possible as well. Now, I'm not going to spend too much time on dietary guidelines because you're a group of dietitians who could probably be teaching me some information. But just to note that there are several dietary guidelines that are out there for pediatric obesity. The American Academy of Pediatrics used to recommend the 5210 plan, but in their most recent guidelines from 2023, they basically stated that successful interventions use nutrition counseling without a structured diet. And what they also said is that single component interventions, such as physical activity alone or sugar sweetened beverages to focus on, are generally not successful. And so using a very global look at what the patient is eating and how we may be able to tweak the diet can be very helpful and beneficial. In addition, again, you already know all of this, but we want to remove all sugar sweetened beverages, try to avoid fast foods and foods that are high in sugar and processed carbohydrates, increasing fiber in the diet, as well as increasing family meals and to avoid watching the screen while eating. And both the AAP and the Endocrine Society recommend portion control education, as well as scheduled meals and snacks to try to avoid grazing. In addition, the Endocrine Society recommends at least 20 minutes of vigorous to physical activity 5 days a week, and the American Academy of Pediatrics recommends at least 60 minutes per day of moderate to vigorous physical activity. Other guideline recommendations include fostering healthy sleep patterns. In addition, we want to prescribe counseling if needed, and that counseling should be tailored to the child's developmental stage, including socioeconomic, cultural, and psychological characteristics of the patient and their families. The American Academy of Pediatrics also recommends a very holistic approach to obesity. So not only do we want to be treating the obesity, but we also want to be treating other comorbidities as well. And starting at the age of 10 years old, the AAP recommends starting to screen for medical complications with lab work. And if you have a patient in the obesity category, lab work consists of lipids, glucose, LFTs every 2 years. In addition, the physical exam is very important, including looking for acanthosis nigricans, which can be a sign of insulin resistance. So this is a patient of mine, a 16-year-old who presented with her mom for weight management, and she had been under my care for about 4 years. And when she presented, she had GERD, migraine headaches, elevated LDL cholesterol, poor sleep hygiene, and the BMI was in the overweight category. She rarely ate fruits and vegetables, and she would walk to school in the morning and would go to the Dunkin' Donuts with her friends, and she grazed on snacks in the afternoon after school. And she was very sedentary, and throughout the 4 years I worked with her, she just was not in the active stage of change. She really was not willing to increase her physical activity. There really was no movement on increasing fruits and vegetables, and she continued to go to Dunkin' Donuts with her friends. And when she presented, again, her BMI was at the 92nd percentile in that overweight category, but over time increased to the 95th percentile, which placed her in the class 1 obesity category. And you can see that when we started with her, we started with lifestyle intervention, and we did get a little bit of success with that. And within 6 months, her GERD, migraine headaches, and LDL had resolved. And you can see that, however, that during her tween years, that her BMI percentile started to increase again, but she was able to eventually flatten her curve, the BMI curve. And she did this by reducing her snacking. So the moral of the story is that even if patients are not following your instructions, you need to meet patients where they are, and they may surprise you. And so it's important to not give up and to continue to work with them. We also need to recognize that lifestyle intervention does improve outcomes. And you can see here, this was a meta-analysis that was done showing a 1.25 kilogram per meter square decrease in BMI. However, if you have a patient whose BMI is at 40 and you reduce it to 38, well, you still have a long way to go. And so a more aggressive treatment will certainly need to be implemented. In addition, lifestyle intervention does help with reducing LDL cholesterol, triglycerides, and fasting plasma glucose. And so with more aggressive therapy, this can include using a dietitian or a social worker or a psychotherapist. And so not only are we looking for and giving information about dietary guidelines, but looking for other problems that may be an obstacle for our patients to lose weight. Therefore, identifying social determinants of health. In addition, looking for mental health causes of weight gain, including medications that the patient may be taking. Studies show that motivational interviewing is the only technique that is helpful with helping patients lose weight. And our psychotherapists may also implement cognitive behavior therapy as well. So in terms of lifestyle intervention, again, this is about a 3 to 5% weight loss. Very low calorie liquid diets show about a 6 to 10% weight loss. And IBT, which is intensive behavior therapy, shows about a 4 to 6% weight loss. And so in order to be a little bit more successful, we have the anti-obesity medications. And you can see that there's a wide range of effectiveness, but the effectiveness of AOMs is becoming more and more successful. Gastric banding is not FDA approved for children or adolescents. And so now we have gastric sleeve and the gastric bypass procedures, and the AOMs are becoming more and more close to bridging the gap between these outcomes. So it's super exciting time right now. So how do these medications work? So from a bird's eye view, we think what is happening is there's something called the set point. And this is similar to what happens with temperature regulation in our bodies. So temperature regulation is found through the hypothalamus. And what the hypothalamus does is it sees this increase in body temperature and it detects that increase in temperature and then tells the rest of the body how to effectively help with reducing the temperature. The same thing happens if we're out in colder weather, let's say skiing, and the hypothalamus will detect a fall in the temperature. And therefore will signal to the rest of the body to try to get that temperature up. And that set point is at that 98.6 degree Fahrenheit. For fat mass, unfortunately, what happens though with that set point is that it becomes higher and higher based on the body fat mass. So if you have a patient who has gained a significant amount of weight, say 20 or 30 pounds, that fat mass set point will continue to climb and it does not come down. And so we have this obesogenic environment, including abnormal dietary constituents, a lack of physical activity, sleep deprivation, stress, disrupted circadian rhythm, and weight-inducing medications, all working to increase that set point. And we have the anti-obesity medications that are helping to reduce that body fat mass set point. The American Academy of Pediatrics recommends that any adolescent starting at the age of 12 years old with obesity be offered pharmacotherapy as an adjunct to intensive health behavior and lifestyle treatment. They also go on to say that children ages 8 to 11 years old of age who have obesity and have other significant comorbidities also be considered candidates for an adjunct to intensive health behavior and lifestyle treatment. In addition, the AAP recommends treating early, and their guidelines used to talk about watchful waiting, and they've gotten rid of those recommendations and basically say there is no advantage to waiting. The obesity becomes harder to treat, and there is more metabolic dysfunction that occurs, and therefore it increases the risk of other comorbidities as well. Even if pharmacotherapy is added for intervention, lifestyle intervention should always be included and continue to be emphasized. In addition, most FDA-approved anti-obesity medications have at least a 5% weight loss. Again, that's a clinically significant weight loss in adults after a year in patients with obesity. In addition, if a medication has not achieved a 5% weight loss in 3 months, the idea is then to change the anti-obesity medication. In addition, if a medication is working, we do not want to discontinue this medication. This is very similar to other chronic conditions, which include things like asthma or hypertension. If a patient has their asthma under good control on the medications that they're taking, we do not take them off of their medication. And the same thing holds true for anti-obesity medications as well. In addition, all anti-obesity medications are contraindicated in pregnancy and lactation, and patients may require 2 or maybe 3 anti-obesity medications to improve their weight. This is similar to asthma, hypertension, or diabetes. Now, this is a very busy slide, but I did want to point out that there are currently 4 FDA-approved medications for obesity for patients who are 12 years and older. So the first medication is called orlistat, which is known over the counter as Ally, and studies show about a 3% weight loss. And the mechanism of action is a pancreatic lipase inhibitor. And what the orlistat does is it binds to the fat in the food that we eat in the small intestine, and it binds, and then we end up pooping out this fat. So the side effect of the medication includes flatulence, steatorrhea, oily spotting, and fecal incontinence. So a lot of patients don't really like those, those side effects. However, if a patient can tolerate the side effects, orlistat has also been shown to improve blood pressure, insulin resistance, as well as an improvement in lipids as well. Another medication is a combination of phentermine and topiramate, and the combination medication is quite expensive and usually is not covered by insurance companies. However, you may see that your providers are separating out the prescription, so giving one prescription for topiramate, another prescription for phentermine, that you can use either together or separately. I have many patients in my practice who take topiramate alone, and there is about a 9.5% weight loss. Phentermine is a sympathomimetic, so it is a dopaminergic and norepinephrine agonist, and it can include side effects such as dry mouth, tachycardia. Some patients have heart palpitations, and the topiramate acts on the GABA receptors, which then stimulate the hypothalamus and then lead to appetite suppression. So the side effects of topiramate include paresthesia, so patients may have a tingling sensation in their hands and feet, There can be some cognitive delay, depression, or a spotting on birth control pills. But the most concerning problem with topiramate is that it is contraindicated in pregnancy. It's category X in pregnancy and can cause birth defects. So we need to just be very careful and mindful of the patients that we place on these medications. In addition, there are two GLP-1 receptor agonists, including liraglutide, which is a daily injection and shows about a 5.5% weight loss. Liraglutide and semaglutide are currently very expensive medications and are often not covered by their insurance companies. But fortunately, liraglutide will be going generic by the end of this year. And so that will allow us to have an additional medication that we can offer to our patients. The GLP-1 agonists work both peripherally, so work on the stomach that slows down the rate of digestion, as well as three places in the brain, including the hypothalamus, which switch off the signal for hunger and can be quite effective. The most concerning side effect of the GLP-1 agonist is nausea, with the liraglutide causing the most nausea, and another medication called tirzepatide causing the least. Unlike liraglutide, which is a daily injection, semaglutide is a weekly injection, which is a little bit more palatable for our patients, and it shows about a 12.5% weight loss. I also want to point your attention to another medication that was FDA approved last year called setmelanotide and is FDA approved for patients who are 6 years and older. And these are for specifically 4 different mutations or patients who have these specific mutations, including Bardet-Biedl syndrome, POMC, PCSK deficiency, or leptin deficiency. And these can be quite effective, showing about a 12 to 25% weight loss. And these problems basically occur with the pathway in the hypothalamus, and the medication targets the hypothalamus to help to reduce hunger. These are FDA-approved medications for adults. Tirzepatide was FDA-approved in October and is a combination of semaglutide as well as another incretin called a GIP, the glucose-dependent insulinotropic polypeptide. And with this combination, the studies show about a 17% weight loss. Again, nausea is the most common side effect. There's also the combination of naltrexone bupropion, not FDA approved for children and adolescents, as well as a medication called Gelesis. So you can see that over time, our medications have become much more effective, and the good news is that there are more medications coming up the pike that are going to be even more effective than the pharmacotherapy that we have available right now. So back in the day when I was first practicing, we had orlistat and phentermine alone showing about a 3 to 5% weight loss. Liraglutide, which is again a fairly old GLP-1 agonist, showing about a 5.5% weight loss, again going generic by the end of the year. And then there's the combination of phentermine and topiramate showing about a 9.5% weight loss, semaglutide about a 12.5% weight loss, and then tirzepatide showing a 17.5% weight loss. And then if you add behavior intervention to this, you can add an additional 2 to 4% weight loss. Again, these are showing now about a 21-22% weight loss with tirzepatide. That's getting very, very close to the outcomes that we have for metabolic and bariatric surgery. So then the question is, how do we use these medications? And unfortunately, there's no algorithm that is currently available. If you have a patient who needs to lose a significant amount of weight and a GLP-1 agonist is available through the insurance coverage, then it's probably likely to start a GLP-1 agonist. But unfortunately, many of our patients are not so lucky. And so this is my working hypothesis and how I approach a patient, depending on who you're working with. Everybody has a different idea of which medication to be trying and working with, but this is what I use. And this is based off of a study that was done by Andreas Acosta at Mayo Clinic, published in 2021. And by using this algorithm, they improved weight loss in adults by 6% using the algorithm versus not using the algorithm. And what they did is they took participants and they put them into 4 different categories. So the first category was abnormal satiation. So they took their participants to a buffet, and then the participants needed to let them know when they felt full. And so this group of participants basically had a high number of calories in order to feel full. And these patients were placed on a combination of phentermine and topiramate. The second category was abnormal hedonic eating. These were patients who were eating out of emotion, often had cravings, had higher anxiety and depression scores and lower self-esteem scores. And these patients were placed on a combination of naltrexone and bupropion. The third category was abnormal satiety. So they did transit times of the stomach, and they found that these patients actually digested their food more quickly and felt full earlier. And so these patients were placed on either metformin or a GLP-1 agonist. And then finally, the fourth category was low metabolism. So these were patients, participants who had a low metabolic rate and were placed on an intensive physical activity program as well as phentermine. They also stated in this study that there were some patients who belonged in multiple of these categories and others who didn't belong in any of these categories. And so I have also taken the liberty to add 2 categories of my own. One includes the impulsive snacker. So these are patients you're probably well aware of who come home and they are snacking throughout the afternoon. They may have ADHD or some binge eating disorder characteristics, and topiramate and stimulants work quite nicely for this group of patients. In addition, there are iatrogenic causes of obesity, particularly the antipsychotics. And ideally, what you would try to do is not to place patients on these medications in the first place. I sometimes will work with the neurologist or the psychiatrist, but usually what I try to do is not change any medications if they are working well. And studies show that metformin, topiramate, and the GLP-1 agonists all can help to reduce weight gain caused by medication. So this is a 14-year-old girl who presented to my office for weight management. She has a history of autism spectrum disorder, adjustment disorder, and ODD, and constipation due to a lack of fiber in her diet. Her medications included guanfacine, which can cause weight gain, as well as Miralax. And usually she missed breakfast. This is often very common in children with autism, and often would miss lunch as well. And that was probably due to the guanfacine, which would cause appetite suppression. However, when she would get home from school, as the guanfacine was wearing off, she was ravenous. And so she would graze on snacks from the minute she got home until she went to bed at night. And you can see that we started with lifestyle intervention, and we did have a little bit of success here with lifestyle intervention. But then what happened was that her BMI percentile started creeping up again. And so I placed her on some topiramate, and she's had a nice response to the topiramate. You can also see that she's also had a slight increase in her BMI percentile since her last visit with me. And so if she comes back at her next visit, I will probably place her on an additional medication, probably a GLP-1 agonist, along with the stimulant that she's already taking. So here are some resources that are available for more information about pediatric obesity. One of my dietitians who I work closely with has taken the Certificate of Training in Obesity in Pediatrics and Adults through CDR, and she said that the course is excellent. In addition, the Institute for Healthy Childhood Weight that is written by the American Academy of Pediatrics provides many free modules. And then I'd also like to take your attention to the University of Connecticut Rudd Center. They have health professional training with screening and videos about weight bias, and also have patient education resources that are available as well. So key takeaways today is to diagnose obesity and to treat early. We want to start screening our patients at the age of 2 years old. We also want to use medical and compassionate language and to check in on our own weight bias. In addition, we want to focus on health rather than the weight when we're discussing our patients' health. And in addition, we want to use intensive health behavior and lifestyle treatment first. However, if things are not going well and a patient is wanting to move on, to offer anti-obesity pharmacotherapy for our adolescents with obesity as adjunct therapy. And with that, I would like to stop and to answer any questions. And I thank you for your time today.
Thank you, Marsha. Wonderful. And before, this would be a good time to send any questions in. I do have a bunch of questions that I would love to ask you. Just before we get to that, I just want to remind everyone here that next week we are moving along is Module 4. This is your brain on junk, unraveling the links between ultra-processed foods and cognition. And then also a reminder of our lunchtime webinar on food allergy prevention and management, which is also in March. So we are very busy and look forward to having everyone join us for those events. And now, Marsha, so I have some questions. And fabulous presentation. I know you probably are talking so much about these anti-obesity medications. I think what you don't hear as much about is the usage of these medications in, children or adolescents over 12. So for those who you are prescribing medications, is there a conversation about the use of them long-term and how, is there evidence to support, someone at age 12 starting on a medication and potentially using it forever? I mean, I can't, obviously there's no long-term to show, someone who's been on it for that long, but I'm just curious because, someone who is older and thinking about being on the medications forever is one thing, but someone who's 12, 13 years old starting. So how does that conversation go, and how do you advise those patients and families?
Yeah, so the most important thing is, again, to treat obesity as a chronic medical condition, and to talk with your patients about how this is a disease process, and yes, that the child is likely to have that. Unfortunately, 80% of our adolescents end up who have obesity end up having obesity as an adult. So the biggest risk factor for adult obesity is having adolescent obesity. And the way that I would discuss this is, again, this is just like diabetes. So if you have a 12-year-old with type 2 diabetes, yes, that patient will probably be on medication for the rest of their lives. And the same thing is for the obesity as well. In addition, unfortunately, some of these medications are not very old, but it's very similar to other medications that we give for asthma and for hypertension and diabetes. We do have a track record, though, of these GLP-1 agonists have been used for 17, 18 plus years now for diabetes. And so we do have some, it's not long term, but we do have some long-term information that these medications are relatively safe. And what I would also state is that with the obesity, unfortunately, there is a metabolic chaos that goes on that really affects every organ system of the body. So if you can jump on treatment early, there's going to be less risk of having medical problems associated with all of the obesity later in life.
Thank you. Marsha, with your experience and a large part of your career being at the Hershey Medical Center and working with other providers, students, and what you talk about today with, stigma-free care and addressing weight bias, I'm curious, did you see, those lessons and like, what did you see when you worked in a medical center with students and with other providers? And how did you get to the point where you're an advocate for, these stigma-free strategies? Because I know that there is a chasm, of that education piece, and for a lot of providers for all, dietitians, nurses, physicians. So I'm just curious of that experience to how you got here today with, your message that you're sharing.
Yeah, so as mentioned before, weight bias and weight stigma are prevalent in the healthcare field. And unfortunately, this can be, our staff member who's, drinking a soda behind the desk, and the, child is checking out with the parent and sees, or the candy dish that's on the in the waiting room, etc. So this is unfortunately all around us. And in terms of education, I think that it's really important to get that message out. And there have been a number of studies to try to help our students with uncovering their weight bias and weight stigma. And there's nothing wrong with that. I think that that's one thing. We shouldn't feel ashamed that we have weight bias or weight stigma. We all have stigma and bias. We wouldn't be human otherwise. And what we can do in terms of education is there is a screen to tell us about weight bias and how much or how little we have. And it's going to run the whole gamut, the whole spectrum. In addition, for my students at Penn State Hershey Medical Center, what I usually did, unlike most physicians where you want patients to or students to go in and see the patient, I really wanted them to shadow me so that they could see my language, my body language, how I would approach obesity as a disease process, and wouldn't unfortunately create some sort of tension between and in terms of a relationship between me and my patients. So it is very delicate. It can be a very delicate process. But I think that over time, as we recognize the weight bias that occurs in the healthcare setting, and we're more aware of it, that we will be more compassionate in terms of our care.
That's great. I just was reading a study that talked about, I think the average obesity education that's given in medical school training is around 10 hours, which is just, shocking, I'm sure, to you as a obesity medicine specialist. And so there's definitely a need to talk more about obesity as a disease, as well as how to have that conversation with patients in a compassionate way. Marsha, how do you engage and empower families, parents in the treatment process, especially considering like cultural and socioeconomic factors?
Yeah, that's really hard. What I would always say to myself is that it's really challenging to treat the obesity if there are many negative social determinants of health that are impacting the treatment process. And that the first thing is to recognize that there may be these things that are going on that we don't even have a good awareness of. And it might not even be the child, it might be, maybe the child has a sibling with mental health issues that's causing a lot of chaos and dysfunction within the family. Or maybe there are transportation issues. So often patients wouldn't show up for their appointments. And so, getting to the crux of really what's going on can be extremely helpful. And sometimes patients are not comfortable talking about those things. So that's where that team approach can become very, very helpful. So having the psychotherapist, for instance, find out, what is actually going on within the walls of the family, and what is happening that is making following instructions more difficult. The other thing, again, is to use motivational interviewing, which is compassionate and really tries to find out, how um, uh, what kind of obstacles a patient may have, and also empowers the patient as well to create their own goals. And that can be very helpful. And so if they come back and they've been able to accomplish their goals, then you celebrate with them and hopefully you have them move on to another goal. But if they didn't, um, get to their goal or didn't, accomplish their goal, then it might be more of an issue of creating a new goal. And again, trying to give them confidence because again, what we want are just these small goals that eventually all come together. And then you can look back 6 months later and say, but look at what we've accomplished.
Definitely. Thank you. Okay, one more question, and then we'll wrap it up. But what do you expect from RDs, in their role in this area? Like at what point, if a dietitian is, working with a family, a child, would they consult with the pediatrician to discuss the possibility of using an anti-obesity medication?
Yeah, I mean, I think if you're comfortable and have a good connection with the pediatrician or family doctor about whether a patient should or should not be on anti-obesity medication, I think that having that conversation is really important. And ideally, you're in a group, a team together. And so the whole idea is to work together to have a good outcome for your patients, and that can include anti-obesity pharmacotherapy. So bringing that up with members of the team, including that primary care providers, can be essential.
And actually, I have a follow-up question to that, and then this will be our last one. And do you require that like 3 to 6 month period of that lifestyle modification before, having a more intensive? No, you don't. Okay, that's a recommendation, but it's not necessary if,
Exactly. So
okay.
the American Academy of Pediatrics used to recommend like a stepwise approach. And step one was that, 3 to 6 months of, lifestyle intervention. If I have patients after 2 months who've been doing lifestyle intervention and it's not going anywhere, I've become more aggressive. So do we need, to see the dietitian? Do we need psychotherapy? Do we need pharmacotherapy? And I talk about that at the very beginning. So the very first time that they see me, I give them information so that the expectations are there that no, you don't just give up, you come back and see me. If things aren't working, that's okay because there are other modes of treatment that may be available to your child.
Yeah, I think that motivational interviewing, shared decision making, those all kind of are integrated with giving, the patient the options, the benefits, the risks, and then choosing which one works best. Of course, with your expertise and your guidance, but having all those available options for them is so important.
Absolutely. And there may be families that are really apprehensive to start their child on medication. So, and there may be a rivet. So, the adolescent may really want to be on medication, but the parents don't. And so, that can be a challenging conversation as well. But a shared decision-making process is really important.
It's also interesting, everything that's going on in the medical
Super exciting. It's
nutrition,
super
world.
exciting. Yes.
Yes, it is. And appreciate your time and being here today and providing your expertise on this topic. And I thank everyone, for joining us today. If anyone has questions that they would like me to pass on to Dr. Novick, you could email me, and she also provided her email address and information in the slide deck. But otherwise, I hope everyone has a wonderful rest of the evening, and thank you, Marsha, for being here.
Thank you. It was an honor.
Okay, thank you, everyone. Have a good evening.